Good afternoon, everyone. Very excited to be here with you all to have this very important conversation as it relates to human trafficking. And even more excited to be joined by an incredibly distinguished panel of experts today to talk about the barriers to healthcare. We know that so many survivors of human trafficking will at some point intersect with a healthcare professional. In fact, some estimate it's more than 80% of survivors will intersect with healthcare during their exploitation. And so there's a lot that we can be doing better within this space, better to be identifying and responding, or even providing appropriate services. And we're going to hear some really key insights this afternoon to exactly what is happening within our healthcare sector, what we can be doing better, and really what does that intersection look like. And first, I'm excited to introduce you all to Holly Austin Gibbs, a good friend of mine for many years now, doing some incredible work. And Holly is currently a systems director of the Common Spirit Health Human Trafficking Response Program. In this role, Holly oversees efforts to implement policies, procedures, education, and other resources that assist providers and staff in identifying patients who may be victims of human trafficking or other types of abuse, neglect, and violence, and in offering trauma-informed care and services to affect patients. In 2014, Holly published a book titled Walking Prey: How America's Youth Are Vulnerable to Sex Slavery. I have to tell you, I highly recommend the book. Unfortunately, I'll make an admission to you all, I'm not a book reader, but this was a book that I picked up. And even having been an investigator and been in the human trafficking space for so long, I found it to be incredibly insightful. And so I encourage you all to take a look at that. But Holly, I wanted to start with you. I think that you've had an incredible career in really working within the healthcare space and as it pertains to this issue of human trafficking, but you are also a lived experience expert. And I was hoping that you could share with us a little bit today about how survivors are seeing, or those that are in exploitation at that moment, are seeing the healthcare system. Are they trying to access it? Do they want to access it? And in what different ways?
Thanks, Bill. Thanks, everyone, for allowing me to be a part of the panel and sharing a bit about what we've learned at Common Spirit Health through our human trafficking response program. So, yes, I bring my own lived experiences to this program and this topic. In my book, Walking Prey, I share my personal story and my encounters with various systems, including healthcare. So, as a 14-year-old victim myself, I was trafficked in Atlantic City, New Jersey by a man that I met at my local shopping mall. And when I was recovered by law enforcement, I was taken to the emergency department. And this is going back to the early 90s, prior to the Trafficking Victims Protection Act. And so there wasn't a lot of education or maybe policies or procedures in place for this particular type of violence. In fact, I think before the TVPA, it was more, there was still a lot of shame and blame projected onto the victims. And that's how I felt. I felt that shame and blame from myself and from those around me who were trying to help me. So in my situation, I was taken to an emergency department after I was identified as a victim by law enforcement. So I think it's important to keep in mind for anyone who's thinking about implementing a program within healthcare to identify and assist victims of trafficking, that you may see victims while they're being trafficked, either alone by themselves, and perhaps they know that they're in a situation of trafficking or other type of abuse, or maybe they don't know it, or maybe they know it and they're ready to accept help, or they're not ready to accept help. And then of course you may see people who are under the control of the trafficker or abuser. So I just want to point out that a lot of times we have this image in our mind of exactly what this person is going to look like coming in, and a lot of times it includes someone controlling that person. And we know from survivors of both labor trafficking and sex trafficking that many times a survivor will, or victim or survivor will come into a healthcare setting on their own and may not disclose information to the provider or staff for many reasons. They may be fearful of authorities, they may be fearful of their immigration status being a concern, they may be fearful of the traffickers. They also may see this situation as their only way to survive, or they may have some sort of feeling of obligation to an employer. There are a lot of barriers to a victim or survivor disclosing. And then, of course, there's barriers to providers and staff reaching out and asking questions. And that begins with education. That's what we do at Common Spirit. We never stop educating our providers and staff about human trafficking and trauma-informed approaches to patient care, when including victim assistance, once we identify that a patient may be a victim. So I can talk more later about the tool that we developed to walk into a room and talk to a patient about any type of violence, including human trafficking, and offer victim assistance in a trauma-informed manner. The tool is called the PAIR tool. But before I share about that tool, I just want to underscore one thing, and that's that victims and survivors can present to healthcare settings on a spectrum, meaning that I myself, as a person who was about to become a victim, an 11, 12, 13-year-old kid, I was vulnerable to being targeted by a trafficker or another abuser or predator. And I came in regular contact with healthcare, including the health professional who was in my school. So those are spaces that could offer preventative education to youth. Or there are other public health spaces where we can think about providing preventative education to people who may be vulnerable to being targeted by a trafficker or another predator. And then again, you may have people coming into healthcare who are actively being groomed by a trafficker or actively being trafficked, and there may be lots of barriers between the victim disclosing and the provider identifying. And then please don't forget that there are victims and survivors who are hours, days, weeks, months, and years past the experience of being trafficked or experience other type of violence. And that experience may still be affecting their health and well-being. So for me, when I encountered healthcare at age 14, having been recovered by law enforcement, I was in a state of crisis. I was mentally and emotionally shut down. My family and I weren't necessarily ready in a place to hear from a health provider about what resources were available to us. We were just trying to get through the night. But when I saw my OBGYN a few days later, and when I was put into a mental health facility because I was in a state of crisis, all of those opportunities would have been time to talk to me about what resources are available to me. But again, I still go and see my health provider, my dentist, my OBGYN, my dermatologist, and my experiences from childhood, as we know from the ACE study, including the trafficking experience, all of that still affects me over time. So if you want to know what survivors are saying, we are saying recognize that we still need health services 5, 10, 15, 20 years later. It's still affecting us, and we're grateful to all the healthcare providers and professionals who are stepping in to learn more and to try to identify and assist both victims and survivors.
Awesome. Thank you. And I think it's so important when you do finally get access to that healthcare to make sure that it's appropriate healthcare. But we know that there are a lot of barriers to survivors being able to access it. And we know that some of that is within the hospital systems themselves and I think some of it is, to your point, Holly, the identification. But I wanted to turn to Heidi Olson. Heidi is a nurse. There's a lot of letters behind Heidi's name and really impressive resume. But most importantly, a certified pediatric nurse and certified pediatric sexual assault nurse examiner. And Heidi's really worked as a practitioner in the field with a lot of these survivors, but she's also the founder and president of Paradigm Shift Training and Consulting, which equips healthcare workers with skills to be able to identify and treat victims of trafficking and exploitation. Heidi previously managed the same program at a large children's hospital where she performed, reviewed over 1,500 pediatric sexual assault exams, and many of them trafficking cases communicated through a large multidisciplinary team. And so you've really seen from that practitioner standpoint how coordination and collaboration works, how you can really bring together good policies around screening tools to be able to identify those that have experienced trafficking or other forms of sexual assault. And I wonder if you could share with us a little bit today about how that works from the practitioner standpoint. What are those policies that need to be in place within the hospitals to make sure that we're activating those right services and working within those multidisciplinary teams?
Yeah, sure. Thanks for having me. It's an honor to be here. And Holly, thanks for sharing everything you were saying. I was just like, yes, agreed with all of it. I think tracking's complex, especially with the healthcare system, because there's not this one size fits all. A 4-year-old who's being sold by his parents in exchange for drugs is going to present differently to the healthcare setting than 15-year-old who's being coerced to be on OnlyFans versus a 24-year-old who's, being sold by a trafficker. They're all going to look different, but they're all experiencing exploitation and trafficking. And so I think as healthcare workers, we want just this very black and white thing where we can check all of our boxes and be as efficient as possible. And that is not the way it works with trafficking. And so I think sometimes there can be resistance within healthcare systems when you start to talk about doing these things, which I have spent the last year with my business trying to talk to hospitals about, okay, this is important. You're seeing it. How do we make changes? And there are so many barriers basically that get thrown up, which is this doesn't make money. How is this going to benefit us financially? Of course, I'm sure all here think it's the right thing to do, but that's not enough to convince hospitals that good training is needed and that screening and that protocols are needed. So they want to know how it's going to bring in money. I've had hospitals say, no, we're not going to prioritize this because we don't have outside resources to send victims or survivors to. So we're just not going to identify. To me, that's an unacceptable answer. We have to prove that there's a problem to have resources be created. We've heard hospitals say we don't have the staff, we don't have the time, we don't have the money, on and on. So I'd say for most hospitals, unfortunately, no one is there is not a systematic, we're on top of this. When we suspect it, we know how to intervene. It is the hospitals who are doing that are very far and few between. So kudos to the ones who have taken it on because it's so important. But I would share from my own experience, I started in that same place of I was never trained on trafficking as a new nurse. I didn't learn about it in nursing school. I did not learn about it as a forensic nurse. I think there was like a tiny little segment of human trafficking is forced fraud and coercion. Okay, go do your job. What does that mean? What does that mean to me as a nurse? So I start seeing patients on my own. I have no context for this. And I'm seeing sexual assault patients or what I think are sexual assault patients. And very quickly, I start to realize I'm looking at trafficking. I don't know what to do. I don't know what questions to ask. And nobody around me knows what to do. So we had one situation with a 16-year-old and we utterly failed her. In my gut, I knew this kid was being trafficked. She had every sign under the sun. I knew it was not just sexual assault that I was looking at, but basically every outside agency we called was like, we don't know what to do either. And it was so disheartening. I felt like I was going to throw up when I left the ER that night. And of course she ran after we discharged her back with grandma. And I think for me, I just felt like we failed this kid. We have got to do a better job. And so that sent me down a rabbit hole of reading, researching, talking to survivors, getting my hands on every resource I could find to say, what do we actually do as healthcare workers? And so thankfully, there are people like Laura and Holly that have and are providing education to help us with these things. And the program that I was working in, we felt like it was really important to start to screen kids for trafficking because as a nurse, I can tell you, I've never had a victim say, hey, can you help me? I'm being trafficked. That's never a scenario I've encountered. I've seen hundreds of trafficking victims or victims of exploitation, but they, just like Holly was saying, they don't present and say the words trafficking. It takes us knowing what to look for and asking the right questions. So we implemented a screening process in our emergency department several years ago. We mostly are just screening kids coming in with sexual assault disclosures because we know those kids are high risk, and sometimes other things like substance abuse, STI testing, things where there's other concerns. And we've been identifying about 100 kids every year coming through our emergency department, either that are high risk or we know there's some level of exploitation. That's not every kid in our hospital. That's not every high risk youth in our city. So to think about, if we're capturing 100 kids where there are concerns, the numbers are so much higher than I think the healthcare world ever fathomed. But again, these kids aren't coming in meeting the stereotype that are in healthcare workers' heads. It's kids coming in saying, I'm suicidal. I was sexually assaulted by someone at a party, whatever it may be. And when we ask the right questions, it starts to become apparent they're actually being exploited. So this is so important for healthcare workers, but I think we have to have the right systems in place to actually be effective and start to uncover this. So I think there's multiple barriers and it's complicated, but I do think that we can make a big difference in this.
Yeah, thank you, Heidi. I think, absolutely. In looking at where those successes are, right? Who has policies that are really moving the needle, that are making sure that systems, healthcare systems in particular, are reacting to potential victims when they encounter them, and that they're able to provide the appropriate care, I think is so incredibly important. And so thinking about policy and thinking about all of the different components when you start to think about government and all the other folks, I'd like to turn to my friend Laura Lederer. Laura is beyond an expert. Laura's been in the fight for many years now and is a subject matter expert on human trafficking and president of Global Centurion, which is an anti-trafficking NGO. She continues to serve as a subject matter expert at the U.S. Department of Defense, has previously served and still consults with U.S. Department of Health and Human Services, U.S. Department of State, and was involved in the fight even before the State Department's Office to Monitor and Combat Trafficking in Persons was stood up. So she was a big piece of that particular effort there. Laura has done quite a bit of work in really helping to identify what are some of the specialized needs of survivors? What are some specialized conditions that survivors may have that necessitate a even different response from healthcare? And so in particular, those that are currently pregnant, those that may be experiencing homelessness or addiction to certain illicit substances, et cetera. And Laura, I wonder if you could share some of that. What are some of the barriers for those that have more specialized healthcare needs? And why aren't they able to access the same level of services that, say, expectant mother in suburban Northern Virginia might be able to access?
Thanks, Bill, and thanks for having this great panel. I think I like to say, even though we've been working on this for many years, we're still in the foothills of consciousness, particularly on the health side. We saw this for so long as a law enforcement problem, which it is, and as a human rights abuse, and only recently begun to see that it's a huge health issue, both public and private health issue. And I became involved in it from a first study that we did in 2014 with 300 survivors. And so I just wanted to special thanks also to Holly, who's participated in a couple of the surveys that I've been doing recently. But we have all this information because of survivors. It's survivors who are telling us. They know the hell of it. They're helping us to understand what they're going through in terms of their experience being trafficked, but also all the various health issues. And then, as Holly said, before, during, and after, and sometimes many years after, and whether it's physical health issues, acute or chronic, or mental health issues. And we're just beginning to understand also the emotional and spiritual health side of this. We've got a lot more work to do. We've uncovered that there's a problem. And as Heidi said, now we know there's a problem. Now we know that 87% of, at least my study said, 87% of trafficking victims sought healthcare during the time they were trafficked. And now we need to figure out how to help healthcare providers understand that they are first responders, and they may be the only first responders. And I think training is important, and education and awareness is important, because there are barriers on the health provider side, and Heidi's touched on some of them. And then there are barriers on the victim side also. The work that we've done recently on pregnant trafficking victims has shown us that they again are seeking healthcare. 90% in a pilot study. I'm involved in a much larger study that's going to go across the whole United States right now. But we thought we should publish the pilot, which was in 4 cities. And it's just out yesterday, actually. And I'll give you the link to the paper, which is in Issues of Law and Medicine. 90% said that they sought health care during the time that they were pregnant. 80% went to an emergency room. 58% went to a clinic of some sort, either an urgent care clinic or a neighborhood clinic, and 35% saw a private physician. And so we know that we need to be reaching all kinds of healthcare professionals across a huge spectrum, but mainly right now in the ER. And what these survivors told us was that even though they were being treated, they felt that the medical professionals, the care that they got was delivered with excellence only in 12% of the cases, and that they were trauma informed only in 9% of the 9% of the time, and that they made referrals only 6.5%, and that they did follow-up only 9%. Very, very low ratings of how the healthcare profession responded to them. And they also said that very few healthcare providers thought to ask a little bit more about what their situation was and to try to uncover whether they were being trafficked. They just treated what was in front of them. And that's not bad. That's important. You have to treat whatever is the problem that the patient presents with. But finding out a little bit more about what the underlying circumstance is and uncovering that slavery or slavery-like situation is just critical. Otherwise, you're unknowingly and unwittingly facilitating the trafficking. And that's going to be important. And that is part of, I think, the work that we're beginning to do now is to help healthcare providers understand that they're in a critical and unique position, and that they have a vital role to play in identifying survivors or identifying victims and in helping to respond appropriately. I'm also involved in a study in Detroit right now that has about 87 respondents. And here again, 74% had sought healthcare, most of them from an emergency, 83% from an emergency room, 8% from a clinic, and 9% it's street outreach. So those mobile clinics that go around. And here I was absolutely shocked to find, we asked them what were the barriers to healthcare, and 43% said no ID. They had no ID and they couldn't even get in the door. And so that just seems like it's such a basic thing. And 42% said no transportation. They had no way to get there. And then 18% said, I think both Holly and Heidi, you both touched on it, that there was shame and fear and embarrassment and just this feeling like, what will they think? And 18% said that was a critical reason why they did not seek care. And then 4% said that they didn't know where to go. And 4% also said that there were very rude staff or judgmental people that they thought were just not going to treat them well. And we had heard that before in many of the survivor stories. Survivors said they had just unprofessional responses from professionals. So these are telling us that there are barriers on the victim side and there are barriers on the health provider side, and we have to be addressing both of them at once. And the other thing that we uncovered in the Detroit study is that oftentimes the services that are being provided are siloed, and they're siloed in a way that the victims are saying, victims and survivors, because Holly, you're right, there's a whole spectrum for a whole long period of time. Victims and survivors are saying that I was drug addicted, and so I couldn't get into a shelter. I had a child, and they turned me away from the trafficking shelter because I had a child, and they were going to separate me from my 2-year-old. And so I'd rather live in an abandoned car for the winter. And So all kinds of issues. I had a criminal record. I had all of these kinds of things are stacking up in a way that's making it very difficult for victims and survivors to receive the kind of care they need. So breaking across or through some of those siloed services is very important. And I think that's one of the things that I love about a Safe House project, is that they are doing this work in a way that is individual case management. What is it that you in particular need? Not here's a shelter and here are the rules and we hope you fit in. All of this is being uncovered by talking with survivors and by listening to survivors and by hearing what it is that their needs are. And I'm a big fan of not just survivor informed and survivor centered, but survivor led services and policymakers. And I hope we'll have more legislators who are survivors. We just need them in every part of this work.
Thank you, Laura. Yeah, I think you couldn't be more right. We've got to have more inclusion of those with lived experience to be able to inform where these policies go, what is the different legislation, how are our systems being changed? We talk about systems change and response at that high level. And I think it's so incredibly important that we have that voice. And so to that point, Holly, I'd like to go back to you and hear from somebody with lived experience and to really think about, you touched on it a little bit in the beginning, and Laura kind of talked about this, different types of access because they're in different stages, or I think you referred to it as a spectrum, right, of exploitation of what they're experiencing. I know one of the tools, we've talked a lot about identification today. One of the tools that you have been extremely influential in drafting and getting out there is something called the PAIR tool. And I recently had an opportunity to meet with policymakers on a global level, both at the United Nations through an event hosted by the Sovereign Order of Malta and a drafting of a protocol that's been submitted to the World Health Organization for consideration. And we know that policy comes in two forms, right? Legislation, but also in directives, policy directives that come out. And so I know the World Health Organization is considering this, and I had an opportunity to speak with World Health Organization in Kenya and WHO in Uganda as well, and present the PAIR tool that you've created to them. And they were very excited about that opportunity and about adopting that as a way forward in the global policy that's being drafted right now. And so I wonder if you could tell us a little bit more about what the PAIR tool is and how global adoption from a policy perspective can really move the needle in being able to tear down some of those barriers to healthcare.
Yeah, thanks, Bill. At Common Spirit, we developed the PAIR tool in partnership with two organizations, Heal Trafficking, which is a great organization to know. They're a multidisciplinary network of health professionals addressing human trafficking, and also an organization called Pacific Survivor Center, which is providing advocating for health and human rights for victims in Hawaii. And so we partnered with Heal and Pacific Survivor Center to come up with an approach to assist victims in healthcare settings in a trauma-informed manner. And I want to be clear that our PAIR tool is a key component of our global abuse, neglect, and violence policy and procedure. We have a policy that encompasses all types of violence that might affect our patient population. We learned early on that it was not helpful to have a procedure focused strictly on human trafficking because, like others have already mentioned, different types of violence can overlap. So someone who's experiencing a sexual assault, they could also be a victim of labor trafficking, of intimate partner violence, of many other types of violence, of elder abuse. We have one policy called Abuse, Neglect, and Violence, and it covers forensic examinations because forensic examinations are often offered to victims of other types of violence, not strictly sexual assault. So the PAIR tool is speaking specifically to the act of walking into a room and talking to a patient about whichever types of violence are of concern and offering victim assistance. So PAIR stands for Provide privacy, educate, ask, respect, and respond. So ideally, in a private setting, we're educating a patient about whichever types of violence we're concerned about. And after having this normalizing conversation about violence, then if we still feel like this person is in danger, we're directly asking if there's anything they would like to discuss, or would they like to be connected with a community service agency. And then beyond that, we are respecting the patient's wishes and we're responding appropriately. So if the person says, no, I'm not interested, maybe the response looks like offering them the National Human Trafficking Hotline card that the person can put in their pocket if we think they may be a victim of human trafficking. There are many national organizations that offer hotline cards for different types of violence. If the person accepts assistance, then that response is a warm referral, ideally. A warm referral meaning a personal introduction to an organization, ideally a local organization that offers victim services. But maybe it's strictly picking up the phone and talking to a hotline professional at the sexual assault response hotline or the human trafficking hotline or domestic violence, and then handing the phone to the patient and creating that connection for them. And once we promote that, once we privately educate a patient, ask if they need assistance and respect their wishes and respond accordingly, then we're following through with what we normally do, which is mandated reporting, scheduling another call, another visit for healthcare, and continuing trauma-informed care for this person. So we offer examples of our policy and procedure and everything that we're doing through our human trafficking response program, including the PAIR tool. All of these resources are available online for free download at commonspirit.org/human trafficking.
Awesome. Thank you, Holly. So incredibly important that we're asking our healthcare providers to do the job. We need to make sure that we're equipping them, right? And especially when we start talking about making sure that we have the different policies in place, directing them to do certain things, well, we got to make sure they've got the tools and resources to do that. Heidi, I wanted to talk a little bit more about once somebody leaves exploitation, right? And now they're trying to navigate different services. They're trying to address physical health concerns, mental health concerns, all of these different components. What is the mechanism to pay for this? Obviously, they don't have insurance, right? Are there barriers there that are preventing those that have now exited exploitation from accessing appropriate services?
Yes, that's a great question. So I actually just met with a nonprofit yesterday, and that's exactly what I was asking. What barriers are you seeing? And they were saying when we have survivors living in our safe home, we actually have people working pro bono, like medical providers and mental health providers, and we're able to get all the things that we need. It's when survivors leave and have more independence, that's where we're seeing those gaps. And I am sure that is probably true at multiple levels. And I'm actually working on a project with a group that provides Medicaid health plans. And what they've recognized is if survivors have trafficking, and of course, there are many instances where they don't have survivors have insurance, and there's many instances where they don't, the insurance they do qualify for is Medicaid. And so what we are finding in this project I'm working on is that a lot of health plans have no recognition of trafficking whatsoever. So they don't understand the trauma component. They don't understand maybe the autoimmune issues that could be related to trafficking, all the long-term things that are related to this type of trauma. No one is recognizing that. And so then a lot of times if they need something, they get denied. So I will give you an example. I have a dear friend, and she told me it was okay to use her as an example. And she was trafficked for 30 years. So if you think about just this lifetime of being in that fight or flight, all of that trauma and all of the abuse, it's just her poor body now has the repercussions of all of that on multiple levels. So in her time of being trafficked, both of her femurs were broken at different times. Of course, that was never properly repaired. So now at this point, she obviously wants to have that be fixed so that she can stand up for a long time and walk comfortably and all of those things, of course. So she went to go see a surgeon and she has Medicaid and she's telling him her situation. And his Medicaid is saying they're denying the surgery right now, even though she needs it, until you get physical therapy, 6 sessions or whatever first, but we won't cover that. So how is she supposed to, if she's not able to work full time? She cannot afford to do 6 sessions of physical therapy, but she can't have surgery to fix her legs that were broken by her trafficker because Medicaid is throwing up these barriers, right? So there's zero recognition of long-term trauma, how it affects our body when it comes to things, especially health plans like Medicaid. So I think that's a huge challenge for survivors. I think also if you think about survivors' bodies, they're used to surviving in deprivation. So they're really good at their bodies are really good at compensating in these really difficult dynamics. So they might be presenting to an ER saying, hey, X, Y, and Z is happening to me, but because their bodies are so good at overcompensating, a doctor might look at their labs and be like, no, they're not. Like, this isn't happening to you. And so I think that creates a difficult dynamic too, because of that extreme trauma, is that sometimes they don't get believed or they don't get the care that they need because their bodies have experienced this extreme trauma, and it's not going to look like maybe a different person who hasn't experienced that when they come into the emergency department. So I think that lack of understanding of how trauma affects our bodies with healthcare providers is a barrier. And then I think our health plans are a barrier. And then if patients or survivors don't have insurance at all, right, then you're going to be denied access in multiple places. Basically, you can just go to ERs. And so I think there's massive barriers to survivors, unfortunately.
Yeah, I appreciate you highlighting that. I think so many people tend to think that, okay, once they're out, right now, the hell, as Laura appropriately defined it, is ended. But really, in some instances, that path to restoration, is really roadblocked, right, by a lot of these different things. And to your point, to your friend, I have some friends as well that have been out of trafficking for many years and are still dealing with the health consequences, or new health consequences are popping up, as a result. Particularly those that have been in sex trafficking are now having uterine cancer and things of that nature that are directly related to the trafficking, but don't manifest themselves until decades later. And so really trying to navigate that. We've talked a lot about the need for identification, incredibly important. We've talked about the need to enact specific policies within healthcare systems and within multidisciplinary teams and systems to be able to react appropriately. We've talked about this barrier with Medicaid and insurance, which is both a federal and a state problem, right? There's solutions to be had at both levels. And I just wanted to round up the conversation. Laura, if you could talk a little bit about what are some of the things that are being done legislatively? What have you seen that's effective? Where do we need to go? What would you say if you were speaking to a room full of legislators, both state and federal, as it pertains to barriers to healthcare? What would you say to them? Where do they need to focus their attention and energy? Are there best practices that they should be looking at?
That is a great question, Bill, and I hope others will chime in too, because I don't have all the answers. I've been working at the state level most recently. Some of us who are involved in this work have developed trainings that are specialized for health providers and even specialized within the healthcare profession for certain sectors like OBGYNs or like the same nurses. And I think those specialized trainings are really important, because we found that what happens when somebody who's a doctor or a nurse looks at a tip 101, a trafficking in persons 101, they come out of it saying, gosh, that's just really terrible, but what does that have to do with me? And what we want them to know is, how does this present in your daily work? And what are the signs and indicators? And then how can you respond appropriately? And the states that are in the lead, I think, in that regard are Texas and maybe a handful of others. I think there are 7 states that have passed legislation where there's a requirement, a mandatory training required for anyone in the health care field. And Texas's law is simple. It simply says any healthcare provider that has direct contact with patients must have an annual training And healthcare providers think they know everything until they get into these trainings. And all of a sudden they say, oh my gosh, now I realize that person I saw 2 months ago, that was a trafficking victim, but I just didn't realize it because I didn't know these signs and indicators. And the best, I think, work that's being done at the state level are these laws mandating or requiring healthcare training. And then Texas has gone a step further. They have an office of their Health and Human Services office has an office of trafficking, and they have set up a kind of a core competencies. Anyone can create a training in Texas, but it has to go through this process and be approved so that they know that you're covering everything that needs to be covered when you're doing a training on trafficking for health providers. And they have a list of about 20 core competencies that you have to include in one way or another. And I wish there were more states that were doing that. We tried this year to get that kind of a mandate in Virginia, and we were only partially successful. We had a lot of wonderful legislators, and I'll just call out in particular Delegate Tata, who took the lead and did some amazing work educating her own legislator, her own colleagues on why it's important to have mandatory training for health providers. We weren't able to get that. We were able to get a law that says that if the Board of Medicine does have training and they want to include trafficking, they can include it. And that's a far cry from that mandatory training, because what we're finding is that those who already know and care about trafficking, they're taking the trainings, they're proactively doing it. It's the people who don't know, and they don't know what they don't know. Those providers are the ones we need to reach. And Texas has a list of the impacted practitioners, and it's a whole 2 pages of all the health professionals, all the health sectors that need to be trained. And it's quite long. It's everything from athletic trainers and audiologists and behavioral analysts and dietitians and dyslexia and massage therapists and midwives. And it goes all the way down all of these types of either health professionals or adjacent health providers that need to be trained once a year. And that's what we need. And we need that in every state.
Well, it's good
And
to
it has,
know.
yeah,
I was
it
gonna
has to be
say,
done at
yeah,
the state level.
yeah, it's good to know that there are examples out there and that we're moving in that direction, but it does take a lot of advocacy, a lot of work. And so, Laura, I'm particularly thankful for your leadership in advocating at the state level. I just want to give a special thanks to all of you. It was an incredible panel, incredible amount of information on a really important topic, and one that, just to reemphasize, at the moment that somebody exits exploitation, it's not over. There is still quite a path ahead of them. And I think access to healthcare is incredibly important. It's an important topic for all Americans. And I think that today we've really highlighted, in particular, for those that have experienced trafficking or exploitation, there remain significant barriers. And thank you, Holly, Heidi, Laura, for all that you've done in this space to be able to move the needle. You certainly have. And I know that you'll continue to fight the good fight. So thank you so much for being with us today.